Hi everyone, welcome to the first episode of our new mini-series, Beyond the Mind, Conversations on Mental Health. In this episode, we will be exploring the bond between pain and the mind. My name is Sangavi.
I'm Jacqueline. We're two medical students who are passionate about women's health and want to take you all with us on a journey to learn more about this underrated side of medicine. In this series, we will be focusing specifically on topics of mental health.
In today's episode, we will be discussing the factors which influence how we perceive pain, including the role of our nerve cells, emotional state, and even the bacteria in our gut.
So, what is pain? The International Association for the Study of Pain defines pain as unpleasant sensation and emotional experience associated with actual or potential tissue damage. Pain is always subjective as each individual learns the application of the word through their own experience. Many people report pain in the absence of tissue damage or any likely pathophysiological cause, and there is usually no way to distinguish their experience from that due to tissue damage. Therefore, pain can be considered to consist of multiple dimensions. Firstly, a sensory dimension, so where does it hurt or how much does it hurt? Secondly, an emotional dimension, so how unpleasant is the experience? And thirdly, a cognitive dimension, so how do we interpret the pain based on previous experience? Does it cause fear and anxiety? And how do we respond to that threat?
So, how is the brain involved in pain perception? In a very simplified manner, pain can be described as involving three steps. 1. The pain receptors on the ends of nerve cells are activated by a noxious stimulus. This could be inflammation or a mechanical injury. 2. These nerve cells then convert the stimulus to a nerve impulse that is transmitted to the spinal cord. And 3. From the spinal cord, this signal is then sent to the brain to be processed. A major feature of the nervous system is its plasticity or modifiability. While such plasticity is often adaptive, allowing things like learning and memory, it can also be maladaptive, driving neuronal disease states. One example is neuronal plasticity in nociceptive circuits in the central nervous system that result in central sensitization. Now, this is starting to get quite complex, so let's break it down more simply. Nociception is a signal sent from your peripheries to your brain to alert the body that there's an injury or tissue damage of some kind. This differs from pain itself, which is a subjective experience occurring after this nociceptive input has been processed. And central sensitization, also known as centralized pain or central amplification, describes pain that occurs when the central nervous system doesn't process pain signals properly and can result in pain that starts in the peripheries being amplified in the brain. There is a large subset of patients where persistent central amplification is present in the absence of peripheral inflammation or injury. This includes patients with migraine and chronic widespread pain conditions such as fibromyalgia or irritable bowel syndrome. Many of these patients have clear indications that central sensitization is present, but how it is activated and maintained is not clear. One possibility is that there may be a genetic predisposition in certain individuals to autonomous pain amplification.
So let's talk more about biopsychosocial models of pain. So throughout the history of medicine, several theories have been proposed to explain why and how individuals feel the pain they feel. The current most comprehensive explanation for the etiology of pain is the biopsychosocial model. This specific theory hypothesizes that pain goes beyond signals transmitted by neurons and is the result of complex interactions between biological, physiological, and sociological factors. Pain is a complex sensory and emotional experience that can vary widely between people and even within an individual depending on the context of the pain and their psychological state. Cognitive and emotional factors have a surprisingly important influence on pain perception, and this can be attributed to the connectivity of the brain regions which control pain perception, attention, or expectation, and emotional states. Imaging studies have confirmed that activity of pain pathways are altered by attentional state, positive or negative emotions, and many other factors unrelated to the pain stimulus itself. For example, simple psychological manipulations such as distraction can have a powerful effect on our perception of pain. A negative emotional state can increase the perceived unpleasantness of the pain without altering the intensity, whereas a positive emotional state can have the opposite effect. There are now numerous studies that demonstrate that patients with chronic pain have alterations in brain regions involved in the cognitive and emotional modulation of pain. This complex interplay may explain why patients with long-term chronic pain develop anxiety and depression, but also why those with cognitive distortion and psychological distress are at increased risk of chronic pain and central amplification of pain. So, how may this impact pain management? In Eastern cultures, the power of the mind to control one's physical state with the use of practices such as meditation and yoga has been recognized for centuries. Western medicine has traditionally ignored the role of the mind in pain control and has focused on pharmacological treatments of pain. Nevertheless, there is now a growing emphasis on mind-body techniques for controlling pain, with many patients with chronic pain turning to cognitive behavioral therapy, yoga, meditation, hypnosis, and relaxation procedures to reduce their pain.
So moving on to an interesting phenomenon that's been receiving increased attention, this is the gut-brain axis. So the gut-brain axis is the bidirectional communication between the gut and the brain through immunological, neural, and hormonal signals. There is new interest in particular to the relationship between the gut microbiota and neurological diseases. The abundance of microbiota residing in the human intestine is estimated to be 3 times the number of human cells in the body. The complexity and diversity of the gut microbiota are established early in the first few years of your life and are influenced by a number of external factors. These include the method of delivery during birth, whether vaginal or cesarean section, whether you were breastfed or formula fed, your diet, any antibiotic medications, infections, and stress. Technological advances in the methods used to identify and quantify the gut microbiome have allowed us to better understand its complexity, not only population-wise, but also its functional complexity. The homeostasis between gut microbiota and the host is essential for the maintenance of health, including energy regulation and immune system function. It's understood that the gut microbiome is a crucial modulator of visceral pain. This refers to pain originating from your internal organs. Recent evidence suggests that it may also play a critical role in other types of chronic pain, including inflammatory pain, headache, and neuropathic pain. In recent years, dysregulation of this bidirectional communication of the microbiota gut-brain axis was shown to be involved in the pathogenesis of many pathological conditions, including neurological diseases such as Alzheimer's disease, Parkinson's disease, depression, and pain. This could be utilized to improve pain management strategies through treatments focused on improving the gut microbiome via probiotics or dietary interventions. Probiotics are living bacteria which can provide health benefits when consumed. The beneficial effects of probiotics have been well demonstrated, including improved digestion, boosted immunity, and a lower risk of certain diseases. Clinical studies have demonstrated the beneficial effects of probiotics on chronic pain in particular. Another interesting fact to consider is dietary interventions. This refers to modifying the intake of a specific food or ingredient in the diet through supplementation or exclusion. For example, the low FODMAP diet is known to alter the gut microbiome. FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. High FODMAP foods include cauliflower, beetroot, mushrooms, and asparagus, to mention a few. As specified in the name, these foods are fermentable, meaning bacteria release gas when digesting them, which can contribute to wind, bloating, and pain in patients such as those with irritable bowel syndrome. Therefore, this disease has been shown to have beneficial effects in these patients, decreasing abdominal pain by reducing this fermentation and gas production. Given the heterogeneity of chronic pain and the complex and diverse nature of the gut microbiome, individual dietary interventions can therefore be developed for management of chronic pain, in particular visceral pain.
Hi everyone, so now we're on to our interview section of our podcast, and today we have Lauren, who has kindly accepted our invite to join us today. So would you like to do an introduction to yourself and also your research?
Yeah, my name is Lauren Rose. I'm a final year law student at Bournemouth University. I have my own lived-in experience as a patient. I suffer with chronic pain and fatigue due to fibromyalgia and long COVID. And I have a passion for patient advocacy and highlighting potential biases faced by patients accessing health services within the UK. And I've recently written a research paper about the patient care and treatment laws within the UK for fibromyalgia patients.
Nice. Nice. So first section of our interview is to talk about conceptualizing chronic pain. So how does your research sort of define and differentiate chronic pain in terms of differentiating from acute pain, especially in the context of mental health?
I would say chronic and acute pain can be differentiated by their treatment. For example, as treatments for acute pain are completely different to long-term chronic pain, for example, like opioid usage and so forth. And the fact that people living with pain every single day adapt to this level of pain and have different thresholds for dealing and functioning with it, as they're expected to carry on their normal lives, yet have this minimal support. I would say chronic pain has there's a lot more psychological factors that go into it, because if you're living with pain regularly, as a consequence of it, people experience depression, anxiety, and so forth, and it's almost a comorbidity of the condition because of the pain you're suffering with and the effect it has on your life.
In terms of, exploring more about sort of mental health side of things, how do you sort of talk about sort of integration of psychological theories in the study of chronic pain in your research?
Chronic pain patients can sometimes feel invalidated and almost treated like that their condition is psychological.
Yeah.
And there have been court cases where it is still seen as a psychological illness rather than a physical illness. So I limited the use of psychological theories within my research paper to more have like an objective viewpoint and have more patient experience rather than the theory side of it.
Yeah. So yeah, as you've discussed, you've talked about some sort of legislations, also in the UK and also in other countries, and also varies widely in terms of the chronic pain management. And maybe there's some strategies that the UK can actually learn from other places as well. So would you be able to explain or elaborate on one example you think would be sort of particularly beneficial for improving chronic pain management in the NHS?
Yeah, for example, in my research paper, I've discussed about how California have implemented 3 regulations with regard to chronic pain patients. Firstly, doctors who are unwilling to prescribe opioids to patients with severe intractable chronic pain have a duty to inform the patient that there are other physicians who can prescribe this medicine. Furthermore, there's secondary guidance that the doctors must complete mandatory continuing education in pain management and treatment of the terminally ill. And the third is a requirement of the California Medical Board to develop a protocol for investigation of complaints for the undertreatment of pain. So other countries have more options to explore, whereas as a patient in the UK, when you go to your GP or a clinician, you are just met with almost like a brick wall. And there's what the clinician says is almost a be-all and end-all. There's no like options to explore anything else, and maybe for chronic pain, like the treatment is very individualized. However, some clinicians have different discretion on how they treat it. So some will take a pharmacological approach, some take the holistic approach, but you can't, when you go see this person, you can't always debate that, or if that treatment's acceptable for you, or you even want that. It's more just, this is what we're offering, and this is what we can do for you, and that's it.
So the next part of our questions were based on chronic pain and mental health disorders. So would you be able to describe sort of the prevalence of mental health disorders among individuals with chronic pain compared to the general population?
Yeah, the prevalence of mental health disorders among individuals with chronic pain compared to the general population is high. As in the article, Psychiatry and Pain Management at the Intersection of Chronic Pain and Mental Health discusses the consequences of living with chronic pain conditions and the causal nature of the comorbidity between chronic pain and psychiatric diagnosis. In studies of pain populations, 30 to 60% of patients report comorbid depression. And I've talked about it in my research, there's almost a domino effect created by the lack of treatment and services available that it affects every aspect of a patient's life. So therefore, their mental well-being is going to be severely affected if they're unable to function, work, hold relationships, and so forth.
In your research, you've discussed how it affects people and their quality of life in all aspects. You've also discussed that how some patients with chronic pain conditions such as fibromyalgia are at risk of diagnostic overshadowing. So this is when new symptoms are attributed to a pre-existing health condition. So how do you think this affects the patient care received by those patients and sort of their mental health and well-being as well?
I would say for a lot of patients, I've discussed it in my research paper, that patients have given the feedback that almost everything is then blamed on their fibromyalgia or their condition that doesn't have many treatment options or cure or anything. And it's sort of left as, oh, that's probably just your fibromyalgia, we won't investigate that. So there's a lack of like further investigation to get to the root cause of it, or how it can be helped, or how your symptoms can be improved. And I've discussed in my research paper about the medical paternalism, and how it's a chronically vulnerable sick patient working in a conversation towards a clinician who, to them, they know everything, and you can't argue that. And yeah, if that makes sense.
Yeah, it must be quite difficult, especially because you mentioned how in the NHS it feels like you're sort of meeting a brick wall when you first come, and then to know that diagnostic overshadowing can also occur, it can be quite frustrating, I imagine, for those patients. And now if we sort of change the direction of the conversation to the relevance towards women's health.
Yeah.
So according to research, around 70% of those who suffer from chronic pain issues are women. So what are your thoughts on this?
My personal thoughts on the high levels of women who develop chronic pain diseases are situated in a lack of care or research towards women's illnesses and pain. Women are less likely to be taken seriously by clinicians due to potential biases, and therefore that affects any of the treatment options. For example, as you've discussed in other episodes about endometriosis, and there is a very long wait for a diagnosis. Same with fibromyalgia. It took me 2 years to get a diagnosis, and pretty much every test under the sun. And there's a lack of belief in the pain, and pain is a very subjective matter. And I feel as though pain in women is not taken as seriously in a medical setting. Mm-hmm. So I think that contributes to a lot of it.
Mm-hmm. So building on the sort of significance of how pain is managed in the healthcare setting, considering it has such a large impact on individuals, one of the statements you mentioned in your article is that pain management is a fundamental human right. Would you be able to expand more on this?
So I would argue pain management should be a fundamental human right. As argued in my research paper, chronic pain patients, when left unable to access services and treatments, their condition will deteriorate. Although fibromyalgia is not, or chronic pain diseases are not specifically seen as progressive diseases or labelled as such, unlike multiple sclerosis, if patients are unable to access any form of treatment, support, it has a complete knock-on effect on everything in their life, whether that be work, career, relationships, money, for example. It affects everything. And my argument is that there should be a fundamental need for an extension to Article 8 of the Human Rights Act 1998 to have a right to pain management for chronic pain patients, or medical treatment that's adequate, and as in the NHS's values, in like, it basically says that you deserve a right to receive adequate and appropriate care. And I would argue that that's not currently being met, because patients are feeling disregarded and validated and not receiving a standard of care that they should be.
Great. So now onto our last section is to discuss more on how you've done certain ways to assess the different aspects of chronic pain, and especially the mental health impacts. What were the sort of methodologies that you've used to assess that?
Currently, in my research proposal, it's secondary research that's been carried out. So in future, my plan is to do a qualitative study, and it would intend to critically analyse the law surrounding the relationship between clinicians and patients with chronic pain, and more specifically looking at myalgic encephalitis, long COVID, and fibromyalgia. And this would be through semi-structured interviews and ethnographic research, discussing with patients, clinicians, the NICE body that write the ethical guidance for patients. And they're one of the main reasons patients are unable to access support, as they control the funding and everything. There are studies that have been conducted of the fibromyalgia services in the UK that have quantitative data and qualitative, and show the broad range of services that are offered depending on your postcode. And it's seen as almost a postcode lottery whether you're able to access any services or not, depending on the funding that's given to your council.
Just for the audience that don't really know what a primary research is, because this is for sort of general public as well, can you describe like sort of ways maybe how the surveys are done for patients to assess how the levels of pain they're experiencing?
For primary research, it's a lot of the ones that have been conducted are discussing how patients feel in their experience through appointments and things like that, and if they felt like their condition's been validated and so forth. And I've included the surveys that have been conducted on fibromyalgia patients, and how pain is such a subjective thing. Mm-hmm. And it's hard to get across how your pain levels are as a chronic pain patient when if you're dealing with excruciating pain every day, you adapt to it, your body learns to do that, compared to like an acute setting where it's like an injury or something. So the surveys basically discuss in depth how these patients feel after appointment, how they feel about the treatment provided and everything. So luckily there's been that primary research has been carried out already.
I guess the subjective part of pain is one of the like main challenges of assessing that chronic pain and how it affects their quality of life. Would you say there are other sort of major challenges in assessing that mental health aspect of chronic pain?
Yeah, I would say it's difficult to sort of assess because, as I've said previously, it's a comorbidity and it's a consequence of your situational like living. There's an argument for, if you didn't have the chronic pain, would you be experiencing these mental health problems, or would it be having such like an effect on you? So it's almost like you have to separate physical and mental health and then almost treat them differently. Mm-hmm. In an aspect. Like when you go to an appointment, they're trying to reduce your symptoms so you have a better quality of life, but you also need the mental health support to be able to even do all this and keep trying and like working on it and accepting your illness, if that makes sense.
Yeah. So yeah, that really sums it up quite well. And as you mentioned in your research as well, you said that currently the NHS provides sort of certain treatments for chronic pain, such as like guided exercise therapy and cognitive behavioral therapy. What are the limitations of these like current treatment plans for these patients?
I would argue there are many limitations with the current guidance offered to chronic pain patients. For example, cognitive behavioral therapy has in the past been argued to be irrational, as in the case of on the application of Fraser and NICE. It discussed the claimant's view of the usage of CBT and GET guided exercise therapy as irrational, as a recommended treatment for myalgic encephalitis. And the court's viewpoint rejected this due to the limited therapies and treatment options available. This judgment was provided in 2009, however, and newer guidelines have been made since. Yet CBT and GET is still offered as primary treatment and management of conditions. However, chronic pain patients can experience post-exertional malaise, where exercise is actually damaging for you and it doesn't give you the same effects as it would in a healthy patient. So I would argue that CBT and GET shouldn't be offered. I don't think it's a successful treatment, and specifically for CBT, it has such a minimal effect on quality of life and how NICE measure patients' quality of life in QALYs. And it's a very expensive thing to carry out with a very minimal benefit. And considering this is a physical illness, I think it's wrong to offer that for when it's not a psychological illness. And I think that further invalidates patients.
Yeah. And what other sort of evidence-based interventions are sort of more effective than the ones that you've just mentioned?
So, for example, there's acceptance-based therapy where you're coming to terms with your condition, and it's less fighting with your condition and trying to sort of like carry on as you were before you got ill, but understanding that you've got limitations and like working with that. So you're becoming more like in tune with your body, and you're more aware of things you can't do, like how much is too much for you. So I would say that's more beneficial to patients than CBT and GET, because chronic pain treatment is a very individualized treatment and it's done based on a patient's symptoms, and not everyone experiences the same symptoms. So if for one person, like I said, like exercise works, that's great, but it's not for everyone. It's very dependent on your individual situation. So I would argue acceptance-based therapy or talking therapy would be a better alternative.
And just to summarize this section as well, what gaps do you think are in the current sort of research of this field of medicine and maybe even women's health, thinking about chronic pain and the representation of women patients, female patients, and also mental health, do you think need to be addressed in the future as well?
I would say it massively needs to be addressed. There's been a massive lack of underfunding and a lack of research into chronic illnesses and chronic diseases, especially that proportionally affect women. And there, first of all, needs to be a proper plan put in place, and research is the first thing that's needed, and everything that's changed in this system of dealing with chronic pain needs to be evidence-based, and it's just having more funding and more resource allocation for this area, considering it affects so many patients, and it can come across as being ignored in the healthcare system currently.
Thank you so much, and that's the end of our interview section. Thank you so much for participating. And that's a wrap for this episode by the Dysmenorrhea Project.
We've learned lots about the links between pain and the mind, and hopefully this has increased your understanding on the complexity of pain and how it is perceived. The sources used in this episode and links for further reading are listed in the description box.
Please make sure to like and subscribe to our channel and follow our Instagram page for more future content regarding women's health topics. In the next episode of our series, we will be doing deep dive into hormones, how they influence pain experiences and impact women throughout their lives. Looking forward to seeing you in the next episode.